Prof دكتور Czupryniak موضوع هو diabetic retinopathy prevention and screening and treatment. Thank you.
Thank you very much. Yes, I'm opening this session, and the topic I will cover in the next 20-30 minutes is about the complication which is probably the most prevalent besides neuropathy in our patients, but also is the one our patients fear most. If we ask the questions, if you ask our patients with diabetes what are they afraid of, the most feared complication is the one, you can see the mouse here, the one at the top, going blind. The next one is losing the limb, which basically these two means that a person become a disabled one once they develop any of those. But still, going blind is number one fear. Interestingly, we in Europe in general, we see less and less patients who went blind, totally blind, due to retinopathy. They have all sorts of visual impairment, and I will be talking about it, but fortunately we managed to stop people with diabetes going blind, at least in Europe. That's what we, that's what we see. The natural history of diabetic retinopathy is, well, nothing new here. It starts with what we call, it is tricky, we call it preclinical diabetic retinopathy, then a mild stage, then a moderate one. This is where some sort of laser therapy already might be indicated. And then, this is what we fear most, a severe non-proliferative. Proliferative means the ones which develops, the case when patients develops new vessels in the back of the eye. I show you a number of pictures. Or we call it pre-proliferative retinopathy as well. And then the worst type, which is vessels proliferating in retina, proliferative diabetic retinopathy, which forms advanced diabetic eye disease. Across the whole spectrum of retinopathy, patients might develop changes in macula, maculopathy, which is also a vision-threatening complication. If we look at epidemiology, retinopathy for years was mostly associated with type 1 diabetes, and obviously after 10, 20 for sure years of type 1 diabetes, almost every patient has some sort of changes in the back of the eyes. In type 2 diabetes, not as many patients develop retinopathy, but they develop it much earlier. You can see here that 20% of patients in this analysis with newly diagnosed type 2 diabetes already had retinopathy. The difference is clear. The patients we always diagnose type 2 diabetes much later after the disease started. With type 1 diabetes, the period of hyperglycemia before diagnosis is relatively short, usually counted in days or weeks. When we look at those sight-threatening diabetic retinopathy, which is mostly proliferative or macular edema, then type 1 again is the leading problem here. It's the group where these two complications occur more often than in type 2. But again, macular edema is also up to almost 20% of type 1 diabetes patients, but it's frequently more and more often found also in type 2 diabetes patients. Sometimes it's difficult to make a difference. Is it macular edema associated with retinopathy, or is it a sort of macular degeneration associated with age? I said at the very beginning that we see fewer patients with going blind, and the progress has been seen very early on. That's the paper from 2011 showing the decline in severe diabetic retinopathy in type 1 diabetes in relation to the time when patients started to have type 1 diabetes. So all those who started to be type 1 before 1975, they ran a very high risk of developing sight-threatening retinopathy, while only if they started to be type 1 diabetic patients 10 years later, this risk is much, much lower. The reason for that is mostly DCCT results published in 1994 showing that intensive insulin therapy decreases the risk of retinopathy hugely. And the other cause was the increasing introduction of laser therapy in 1970s and 80s. So now I will show you a series of pictures describing what we are dealing with when we talk about retinopathy. That's an example of a regular retina on the left. You can see that this is a very complex structure with a network of vessels on retina, and on top of this there are a few layers of mostly neural cells which are responsible for picture reception, but also vessels going through those layers, they are present here as well. And on the right-hand side of this picture, we can see severe non-proliferative diabetic retinopathy with diabetic macular edema. And there are a number of lesions here which are easily identified in every fundoscopy in patients with diabetes. So we may find, and I show you more pictures of the microaneurysms, which is an early lesion in the arteries of the retina. We may see venous beading. It's also the dilatation of the veins in retina. The beginning of neovascularization, but very small, so that's not yet developed in the full proliferative diabetic retinopathy. And something we call cotton wool spots or hard exudates. This is the serum leaking from the vessels, which forms that sorts of lesions in retina. They are rich in lipids, then we call them hard exudates. But also, in the lower part here, you see the cyst full of fluid, and this is macular edema with an immediate risk to cause retinal detachment, because this fluid here, between this layer of the vessels and retina, is a subretinal fluid, and if it accumulates, it may lead to retinal detachment, which means loss of the vision of immediate nature. So now let's go through a number of pictures ophthalmologists usually see. If you were in UK 20 years ago, 30 years ago, you would probably, you could ask every endocrinologist, because the doctors treating diabetes regularly also assessed the eyes. It stopped to be the case because of the changes which were introduced in Britain, a very successful program in retinopathy screening. In other countries in Europe, we usually do not do it nowadays. If we have any suspicions, we refer patients to ophthalmologists. But still, we should be able to know what might be found in the eye of a patient with diabetes. So that's a regular, proper human eye with no changes. There are structures we should all remember from our studies still. There is an optic nerve disc here which doesn't take part in vision formation, and the most important part is here in the middle. We call it the macula. This is where the picture is created, and the central part of it is called fovea. It's a little bit darker than the rest of the surrounding area. We also have a frontal part of the eye with a lens, and this is where cataract occurs. But I'm not talking about the complications of the frontal part of the eye this time. So that's the view of the normal retina with the macula, which is this most crucial part, and the fovea in the middle, the darker one, as I showed you. You'll see the picture of macular edema when the central part, being slightly darker, becomes pale or paler, and that's the sign of macular edema. And there is two sets of vessels. One artery is going to the upper and the other artery is going to the lower part of retina. So this is how it all starts. We may see the arteries with a small dots alongside. This is in a larger magnification, and these are microaneurysms. This is the endothelium, which starts to be damaged by hyperglycemia. Endothelium is a 100% non-insulin dependent tissue. So if there is a lot of glucose in the blood, it goes in only depending on the concentration in the blood. It goes into the endothelial cells. they go berserk, they don't know how to handle that amount of energy, they weaken, and those microaneurysms are the first signs of any damage hyperglycemia might cause in the eye of patients with diabetes. That's a more advanced stage. We have small hemorrhages because those microaneurysm might cause a little tiny hemorrhages, all these red dots here. We can't see any new vessels being formed here. It's still a non-proliferative diabetic retinopathy, but clearly a more advanced stage of diabetic retinopathy. And these are the wool spots, which you can also see in the back of the eye. That's the deposits of all sorts of proteins which are in the serum. That's also here, they are visible here, and some small hemorrhages here and there. And that's hard exudates, what we call. They are thick in lipids, rich in lipids, exudates of the serum. The fluid has been absorbed, the lipids remained here. It's also the example of an increased leaking and imperfection of vessels in diabetic retina. There's again another picture. You can see small dots here. They are the lesions. It might require a little 1 or 2 courses of laser therapy already, and there are hard exudates on the peripheral parts of this retina here. And that's the complications we fear most. Here in this resolution, the screen, you should be able to see at least 2 or 3 sets of new vessels which have been formed here. One is in close to the macula. It's a tiny network of the vessels. The other one is top here, and the third one is at the bottom part here. The mechanisms for development these new vessels, which, as I keep repeating, we fear most, is that because of the vasculature of the eye is damaged, the eye tries to improve the arrival of oxygen to retina, oxygen supply, by creating those new vessels here. But the trick is that all our, it's not me, it's all our vessels we have in the eyes are being formed when we are in our mother's wombs, when we are fetus, at our fetal age. And later when we are born, those vessels only grow longer, thicker, but there are no new vessels being formed. So anything which is formed later in our adult life in retina are not properly built vessels. They have very weak wall, and they are very much, and you can see it, of a very tortuous course here. And they bleed easily. And that's the case of bleeding from new vessels here. If it happened, the patient sees it, the patient immediately realizes something goes wrong with my eyes. If it is in front of the macula, then they stop seeing anything. And this bleeding, the blood goes into vitreal fluid, and it is also not just important because patients don't see anything, but if this blood communicates with retina here, and then is being removed by macrophages, because what happens there is what happens with every scar. So if you ever cut yourself, then you see easily that the scar, creation of a scar means that the proteins contract, the skin is pulled to close the wound. The same happens here. This blood clotted and it contracts later on, and it may pull retina from the bone at the back of the eye, and may be an immediate cause of retinal detachment. So we try to avoid it as much as we can, and we also treat it when it occurs. But at first, when there is a massive bleeding, quite often ophthalmologists decide to wait a few months, because this also could be absorbed and leave little or no sign afterwards. That's a more intensive bleeding. The blood is really filling the vitreous fluid, so it's a vitreous hemorrhage here. And then after up to 6 months, sometimes ophthalmologists decide to wait. The blood might be removed completely, or what may remain are the membranes of fibrous tissue here and here. It is called sometimes gray membranes. They might block the vision, and the patient may still remain even blind with this. And this is treated with vitrectomy. There is no other way like to remove all those membranes, remove the vitreous fluid, and put some new fluid like silicone oil into the eye bulb. And the last complications I want to show you in pictures is diabetic macular edema. That's the picture with hard exudates here, small hemorrhages, but the center, you can hardly see any fovea here. It's pale, and this is an edematic macula in the center of retina. This is the fluid accumulating at the base of retina here. This has been acknowledged relatively recently, like 15 years ago, and it happened mostly due to the invention of this tool, optical coherence tomography, OCT, which is now used routinely by ophthalmologists. This is the tool which allows to create an image of the retina. This is a normal retina, and the fovea is here, this little pit in the middle. And this is the macular swelling, macular edema, accumulation of fluid in the middle of the retina. So this is a painless examination done by an ophthalmologist, and it's invaluable in assessing the condition of retina. There are several types of macular edema which have been identified. This is a sponge-like, when you have fluid accumulation alongside and across the retina. The cystoid one, when we have clear cysts, and the one which leads to retinal detachment. That's the picture you've already seen. So these are the things which might cause blindness, and if we see patients nowadays going blind, but I haven't seen one for the last 10 years at least, it might be due to macular edema or severe hemorrhage to vitreous fluid. Okay, so what is our task? What can we do? How should we go about? While we leave most of the treatment to ophthalmologists, there is still a lot to do for us as diabetologists or endocrinologists. First, we have to screen. And that's a very practical issue. There is a difference between type 1 and type 2 diabetes patients. In type 1 diabetes, when I started to work over 20 years ago, there was a tradition that every patient with newly diagnosed type 1 diabetes will refer to ophthalmologists to assess the retinas. And we've never seen a patient with newly diagnosed type 1 diabetes with any changes in the eyes. Then when I somehow became responsible for patients' management on my own, I stopped doing this because there was no really reason for that. And in this screening algorithm, you might see that screening should be initiated 5 years following the diagnosis of diabetes. The common knowledge is that the patient has to be at least for 3 years type 1 diabetic patient, and the diabetes must be poorly controlled, that he or she requires any changes occurs in their eyes. So you have 5 years if someone is after puberty. Before puberty, it's earlier because of unstable glucose control usually. The Americans also say that you should screen in type 1 diabetes after 5 years after diabetes diagnosis, or when a patient turns 30. So that's another recommendation. What is more important is type 2 diabetes. The patient should be absolutely screened at the moment of diabetes. We always do that. And if the patient cannot have it done while he's at a hospital, when he's admitted with newly diagnosed type 2 diabetes, we usually ask the patients to go to ophthalmologists on their own. They don't need any referral notes and be screened. And then it all depends on the presence of retinopathy. If it is present, if it is mild, 1 yearly examination is enough. But if it's not mild, if it's moderate, if there are some red lesions here, the patient should be screened more often, usually every 6 or even 3 months. In type 2, there is no retinopathy. In type 2, again, it could be 1 or 2 years. In type 1, in type 2, they say now the discussion is in US that perhaps if there are no changes, the patients might be seen every 2 years. But I guess a yearly examination of the eyes is a good practice in diabetology. What I tell my patients is, look, where have you been, when did you go last time to ophthalmologist? And they say, well, now we have November, and let's say they would say, oh, in March. So I say, okay, remember, every March you go to ophthalmologist. Whether you're referred or not, remember, like in my country, we all know that there is a Christmas is in December, so your ophthalmologist is in March. Just make a point like that, because it's largely patient's responsibility. It's not really us who should tell them go to ophthalmologist. It's their eyes, and they should remember about it. One thing which happened here, and it changed the screening in a qualitative manner, was introduction at the beginning of the century in Great Britain, the digital screening for retinopathy. It has now over 10 years duration. That's a national program, the one we all envy in European Union. I must say, when I was the president of Diabetes Poland, our association, we tried to engage the Ministry of Health into this program. It requires some spending at the very beginning. The program is basically quite simple. In every outpatient or inpatient clinic, you put a fundus camera, you put a digital camera, and you employ a person. Doesn't have to, shouldn't be a doctor, doesn't have to be a nurse, could be a specially trained person who perform the digital pictures, does photography of the retinas in any patient who comes to this clinic. And the key for success of this program is that these digital pictures are then sent online to the few centers, or could be one center if the country is small, to one center where ophthalmologist, trained ophthalmologist, quickly assess, is there anything to do here? It's not an ophthalmologist in every clinic is not necessary. They should be, the assessment should be somehow centralized. And persons who are involved in this are also the people who are involved in UK PDS program, for example, like Irene Stratter, one of the leading statisticians there. And with all the difficulties the program had, it is regarded as a success what was managed to be introduced in UK. A similar program works very well in Singapore, but it's a much smaller place and also much wealthier, I believe. But this is something we should all aim for. There is no more the time where all of us could individually assess the back of the eye is past. Of course, it's better than nothing, but you have scarce ophthalmologists. But this is something which new technology is allowed to do and should be performed in every patient. So that's about the screening. What about the treatment? Well, on our part, we should control diabetes as well as we can. We all know it. That's one of the canonical slides from DCCT. Again, type 1 diabetes patients, those who are in intensive therapy group had much lower risk of developing retinopathy. And interestingly enough, in every long-term study, whether in type 1 or type 2 diabetes, in all the studies which aimed at assessing the effect of lowering glucose on macrovascular complications, they sometimes failed, but they always showed the beneficial effect of lowering blood glucose on retinopathy. This is a very hyperglycemia sensitive complication, so whatever we treat, however we low glucose in our patients, lower it, we always saves the eyes. And it also has been very well documented in UK PDS for type 2 diabetes patients, where lowering HbA1c by 0.9% over the course of 10 years since the diabetes diagnosis decreased by over 20% the risk of retinopathy. The actual reduction nowadays could be much bigger, because this study was started in late 70s. Diabetes was diagnosed at much higher levels of glucose. Nowadays we could be even more effective in eliminating retinopathy. If we fail, or the patients fail, or we altogether fail, and the patients do develop any changes in the vasculature in the eye, then it's time for panretinal laser photocoagulation. This treatment looks kind of a brutal one, and it's actually quite primitive in terms of how it is done. But it works very well in prevention of the advancement of retinopathy progression. If you've never really heard or thought about it, the idea of the treatment is to destroy with a laser or peripheral part of retina, but leave the middle part where the macula is intact, and thus to increase the blood supply to the center of the retina, because the blood can no longer reach the peripheral part of retina. So, as I said, it's pretty primitive and brutal as an idea. But when it was introduced, it saves vision in many patients. It does not restore the vision lost, but because the oxygen supply increases hugely here, the retinopathy progression is very effectively halted. It stops. And the patients go usually several courses of laser retinopathy, of laser photocoagulation, and it is okay, they may stay okay for years. So whenever an ophthalmologist says, well, you need a laser treatment, we should always support it. We also should explain to the patient that it might be painful, because it is painful. It's 200, 300 laser shots in the eye, so it might cause pain during the application. It also may lead to bleeding. That's the risk of this treatment, but it is highly effective. But again, it doesn't restore the vision, so the patient shouldn't have unfounded expectations. We should also remember, and we should also tell the patient, that it will destroy peripheral photoreceptors, but as it happens, we don't use the peripheral retina very much for our vision. It doesn't restore what was lost. We don't really know what is the exact mechanism. This increase in oxygen supply clearly works, but there might be other issues. Potentially it might cause bleeding, which is a severe effect, and it is not much useful, and if it is done only in part of retina. It should be done, the proper name is pan-retinal, so it should go all around retina. And if that fails, or the patient has bleeding, or if simply cannot see anymore because of everything what happened in vitreous fluid, vitrectomy is performed. It is still it's a kind of ocular surgery. Not all ophthalmologists do it, of course. That's a major surgery in the eye, and the main indication is the hemorrhage, which left signs, scars, those membranes in vitreous fluid. Also the risk of retinal detachment, especially if it is a traction detachment. That's the clear indication. For macular edema, it is less and less used because we have more effective treatment, which I will show you in a moment. The patients are not happy when they hear, well, we have to make a surgery, we have to remove all the vitreous fluid, we'll put something new into your eye. But once the patients I've seen, they usually see better. It doesn't, again, restore the vision to what was before diabetes, for example, but the vision improves and the patients may remain self-dependent, which is the main worry for most, or if not all, our patients. So macular edema, how can we treat it? That's again an example, the picture of macular edema in OCT, the central part, the cystoid-like form. Then this type of treatment is nowadays more and more often applied. They are intravitreous injections with number of different agents. I'll show you in a moment. So it looks quite brutal as well. There is an injection into the eye. The drug fills the vitreous fluid, and it acts the way that it either stops the new vessels being formed and stops the leakage, and also decreases macular edema. And that's the effect of this treatment, that this is exactly the same retina you've seen a moment ago, and after the treatment it really restored to normal. The rationale for this treatment, because there are two types of drugs which are used, and most often these ones are used, we call them anti-VEGF therapy, the antibodies against vascular endothelial growth factor. The mechanisms for this is again like it follows here. This protein, this growth factor, controls the permeability of retinal endothelial cells, but also stimulates the growth of new vessels. It is increasingly produced the more retina is becoming ischemic, the more VEGF and other compounds, but VEGF is the well-studied and most prominent here, is produced. So the concept was to produce autoantibodies which would block the action of this growth factor. And as it was shown in the studies I will show in a moment, it clearly works. It also causes the breakdown of the blood-retinal barrier because it is supposed, this growth factor, it is supposed to increase, to facilitate the creation of new vessels. So if we block it, then we block the leakage, we block the permeability, and we also inhibit the formation of new vessels. And that's one of the first studies which documented how effective this treatment could be. This is ranibizumab, one of those drugs which are used with laser or without laser, and you can see that addition of laser was giving no benefit. All what was achieved thanks to the use of this drug, and it improved the acuity of vision, to put it in the most general terms. There are several problems here again. One problem is that the injections are performed monthly, and the patient should have at least 3 injections for the treatment to be assessed whether it's effective or not, because it's not effective in all patients. In majority, yes, but there are groups of people who do not respond to this treatment. Ophthalmologists say that the best thing is to get 6 to 8 injections every month. And the problem is the price, because the drugs which are licensed to be used for this, the cost is about €250 per 1 injection. So it's a lot of money, and it's not reimbursed in many countries. You can use the drugs bevacizumab, which is registered for oncology indications, for example, and you can also use lower doses, and the cost of the injections might come down to 100 or even €50 in some countries, but this is an off-label use, and those companies who produced compounds who are licensed to be used for this treatment are fighting fiercely with these cheaper options. But we still use it because it's more important for the patients to get the treatment than to follow the routine, really, or the procedures. This is the latest study which shows the most. There are 3, I'm not sure if you can read it. One is aflibercept, bevacizumab, and ranibizumab. There are 3 main antibodies used for this treatment. And again, you can see that all 3 improved visual acuity. That's a 1-year observation. But what is interesting here, they are not all effective the same way. The most effective is aflibercept, this green curve. This is the largest, the greatest change seen here. And also, this was a very large study, over 600 patients, multinational, multi-center, blinded, a very well-prepared study. But what they also showed, that the patients who had more advanced macular edema, and these are the patients which in the bottom figures are shown in solid lines, they benefited most. Those dotted lines are the patients with less advanced changes. So there's a good hope for patients who, even with advanced macular edema, they will still have more effective, they can see more effects treated with this expensive type of treatment, but still recommended. And now it has really become a treatment of choice if diabetic macular edema. The other drugs which are used, if we cannot afford these ones, you can use triamcinolone, which is a powerful steroid hormone, which is also used by ophthalmologists. It's anti-inflammatory. It also stops the blood from leaking. It stabilizes the endothelium. So there are some benefits described with steroids given to vitreous fluid as well. And finally, are there any other options we should consider? There are data about fenofibrate, the drug which is used for hypertriglyceridemia, from the field trial and also from the Accord trial, that patients who already had mild background or simple retinopathy, when they were treated with fenofibrate, this slowed the progression of retinopathy. It did not prevent the occurrence of new cases of retinopathy, but slowed the progression. Fenofibrate has not been licensed, registered with this indication, but I personally and many of my colleagues also tend to use it in patients with developed retinopathy. And a word of caution with glitazones. There are quite a few reports, and this is a larger study, showing with the patients who are treated with insulin and TZDs, mostly pioglitazone, run the higher risk of developing, this is the curve, the line which shows the incidence of diabetic macular edema until 10%, which was like 4 times more than patients who were not using TZDs. We simply might increase the risk of macular edema development, and there are some cases being described as well. That's one case published over 10 years ago with pioglitazone here. This is the edema here, and when they stopped pioglitazone, it disappeared. So the drug should not really be used in patients with any suspicion of macular edema present. So just to summarize, what's our role in prevention and the treatment of diabetic retinopathy? Screening is the most obvious thing. No one will do it but us, and the patient should be aware of its importance. Patients should be referred to ophthalmologists when it is only needed. We should explain all the risks and benefits of the treatment, especially anti-VEGF therapy. We should use the drugs with known beneficial effect, and I haven't mentioned that, but it's kind of self-evident. Once we have a patient with retinopathy, we also should screen for all the other vascular complications, be it micro or macrovascular, because very rarely retinopathy is just alone complications. We might expect a neuropathy, nephropathy, but also changes in large vessels as well. So to conclude, the retinopathy, as I told you, might be getting slower, but the number of patients will not be decreasing. We see more and more people with diabetes, and they live longer, so they will develop retinopathy for sure. It is still the main cause of vision loss worldwide, as I said, not perhaps in Europe, but worldwide. We should remember about glucose control, which is very obvious, but not only. I showed you UK-PDS results on retinopathy with glucose lowering, but also UK-PDS showed that blood pressure lowering is beneficial for retinopathy prevention. So, but we do it on an everyday basis anyway. Importantly, there are no drugs which are registered, licensed to be used for a diabetic retinopathy. In my country for years, the drug which was very popular, for example, was calcium dobesylate. You might have heard the name. And it really works like placebo in retinopathy. But still, there is such a need from patients that, okay, the doctor, there is something wrong with my eye, I should be taking some pills to help it. And so eventually they end up with some vitamins, but it also works like placebo. But there are no drugs which have been shown to be as a systemic treatment for retinopathy. Screening is mandatory, laser is very effective, as I showed you, and now anti-VEGF therapy is a standard therapy. The main barrier is the cost, and the governments are not very happy to reimburse it, even in a well-off countries. And we are kind of responsible for preventing and also the treatment of retinopathy and preserving vision in our patients. We mustn't ever forget about it. Thank you very much for your attention.
Thanks a lot, Dr. Czupryniak, for this wonderful talk with a lot of information and new knowledge. Thank you very much. I have one question for you. The role of a vascular endothelial growth factor in the pathogenesis in nephropathy, is it the same mechanism in retinopathy?
Well, not necessarily, because in retinopathy we have there are other factors present, like albumin crossing base membrane in glomeruli. This is something we don't have in the eye. The kidney is filtrating. There are fluids and everything going through membranes, and it's not the same mechanism. There were other studies, because there were reports suggesting that using this in patients who used consecutive injections of anti-VEGF compounds, they've been seen to have improvement in nephropathy as well. So what was injected in the eye somehow got to the kidneys and helped. But it is a sort of a chance finding, and it's not an indication. So it's really the topical action of these drugs in the eye. So VEGF is it's much more important in the eyes than in the kidneys.
Another question, please, about is there any evidence between attacks of hypoglycemia and deterioration of retinopathy?
It is emerging now, because now we look at hypoglycemia as a much more serious problem than we used to. Hypoglycemia, in a way, causes the same effect, what hyperglycemia, but in different mechanism. Because in hypoglycemia, endothelial cells get less glucose, so they also get less energy, they become less effective, and it also leads to the same, very similar, as we now know, damage to the vessels as hyperglycemia. But we lack proper long-term studies, because for years we were fighting hyperglycemia. Now we can manage to bring glucose as low as it is possible, and now we have increased risk of hypoglycemia, but for decades it wasn't an issue. But if you listen, and you still can listen to the excellent lecture of Professor Brian Freer, if you go to EASD virtual meeting website, he received the Camillo Golgi Award for his lifetime 30 years work on hypoglycemia. He makes a very good case at the end of his talk that hypoglycemia initiates all the mechanisms which are very similar to the ones initiated by hyperglycemia. And even if you argue, okay, but hypoglycemia only lasts for a short moment because then patients save themselves, there is evidence showing that after severe hypoglycemia, all those pro-inflammatory, pro-atherogenic changes are maintained up to 2 weeks. So probably we will end up with the same mechanisms, and just mimicking the nature and replacing the control of glucose level at an ideal way, which happens in physiology, will be still a challenge, because even if we control hyper, we will still fall into the risk of hypoglycemia. Yeah.
And about phenofibrate, was it a proved causal relation between hypertriglyceridemia?
It's now well understood. Phenofibrate is a PPR alpha agonist. And it's well, I have no time to explain it, but it's well documented now, also in experimental work, how stimulating PPR alpha receptors may improve oxygen supply in the retina. So, yeah, I'm pretty convinced, and there is evidence that it's not a chance finding. And there are at least 2 studies, Field and Accord, which confirmed it. The only legal problem is that Aasd, the company which produces phenofibrate originally, applied for this registration in retinopathy, but still there is no decision, at least from the FDA. We all follow what FDA tells us to do.
Thank you. My name is Leszek, working in Cairo University. What about the data about GLP-1 analogs when they used some change worsening of retinopathy, like in semaglutide trial and naraglutide trial? Do you have any data why GLP-1 analogs can be worsening retinopathy?
The question is about semaglutide and the 5 cases of blindness in the study. As far as I know, as of today, the understanding is that semaglutide was too good a drug. It simply lowered blood glucose too quickly, and the situations which was found there, is very similar which we saw in pregnant women with type 1 diabetes who were poorly controlled. They came to a doctor and they said, okay, look, I'm pregnant now, I'm ready to change a lot to get my glucose to proper levels. We lowered blood glucose very quickly, because in pregnancy you have no time, and then they experienced deterioration of retinopathy. And this is somewhat what you asked. It's a sudden drop of glucose, and it's further damage to endothelium. So that's how Novo Nordisk tries to explain. It's not the drug itself, it's the potency of the drug in controlling blood glucose. But I guess we need a bit more studies to be fully convinced that GLP-1 agonists are safe here, especially that with liraglutide in LEADER study, there was also a slight tendency to increase retinopathy. So we have to see it. But for me, it sounds plausible. It's just the potency of the drug, not the drug itself. So it probably has to be introduced at lower doses in some cases, or be used in special caution in patients with retinopathy.
How can you manage patients with diabetic retinopathy and at the same time they are in need for antiplatelets for prevention of myocardial infarction or cerebrovascular stroke, and patients also with diabetic retinopathy who are in the stage on regular dialysis and need heparin during dialysis session? How can we manage this case?
So you ask about antiplatelet therapy in patients?
Or anticoagulant.
Anticoagulant. In general.
Antiplatelet or anticoagulant.
Yeah, anticoagulant therapy, patients who need laser therapy. With antiplatelet therapy, the aspirin, everything was stopped a few days before, but that's probably not necessary because the risk of bleeding here is little. When they take these new anticoagulants agents, they are usually stopped for a couple of days before. But again, there is little data that it's harmful. What is done with laser is just it's really, if you've ever seen it, if you've seen ophthalmologists doing it, it's the tiny shots, but of course it may shot the vessel. So if I have a patient who's on aspirin, I usually say it's really no need to stop it. But if they take new anticoagulants, they stop it for a day or two, no longer. There's no need to go on heparin for this, that's for sure. There was also at the beginning the suspicion that they have to be switched on heparin subcutaneously and then have a major laser. Not anymore. But with newer anticoagulants, especially in older patients, probably I go slightly beyond recommendations. I'm quite cautious. But I've seen many old people having severe bleedings after new anticoagulants, and only one of them has antidotum. So it is a challenge. But laser therapy should go first, I believe, because the vision should be safe. Okay, I thought it's a boring lecture. It's what's new about retinopathy.
Is the presence of retinopathy is an absolute contraindication of pregnancy, or it depends on the stage of retinopathy?
No, it's not a contraindication to retinopathy, to pregnancy. Absolutely, it only has to be controlled, and the issue is not to change the glucose control too dramatically. But not retinopathy is not a contraindication nowadays. At least in Europe, we do not tell women, okay, you have advanced retinopathy, you shouldn't get pregnant. They should be under more intensive care in a way. What happens in my country, again, we have a very big maternity hospital in center of the country, and they have two big wards. They look after women who are pregnant and have diabetes. Sometimes they spend half of their pregnancy in this hospital, but we don't discourage them. If a woman wants to become pregnant, she will become pregnant anyway. So, and we also think we shouldn't deny the sort of a blessing of having a child, especially if you have type 1 diabetes. You need care in your later years, and the children should care after you. So no, it's not a contraindication. Okay, thank you very much. I guess we should rush with
Thank you very much.
Thank you.